Thank you very much. Thank you for inviting me. And thank you particularly to all my good friends here in Italy for inviting me. It's a great pleasure to be here. I have very many good friends and I enjoy coming here. I enjoy the discussions. I have been asked to talk on pediatric asthma management, and I have been so bold to rephrase it to my favorite title, which is From a Sneeze to a Wheeze, because I feel it very much captures the essence of early asthma and the focus we should put on viral infections in early asthma, in the origins as well as in treatment. Talk I will give will cover diagnosis and prevalence and the current treatment of preschool wheeze. I will focus on the treatment of the classical persistent chronic asthma, and at the end I will show you some new data on what we know about treating viral-driven symptoms. So these will be the three main topics of my talk. But I would like to start by introducing the patient that I'm talking about. I'm sure you all recognize her. I'm sure you're all aware that this is the most common chronic disease in pediatrics. I'm sure you're all aware that this is the most common cause for hospitalization. We've recently tried to get a better picture of the prevalence of this disease, how often we see it, how it burdens the life of young children, and how we treat them. In order to do so, we have performed a survey of some 10,000 mothers, half of them in Europe and half in the US. In Europe, we split into Northern Europe and Southern Europe. Southern Europe, in this case, being Italy, Spain, and France. We interviewed them by telephone for half an hour with emphasis on the history of the child, 1 to 5 years of age. All the homes had young children 1 to 5 years of age. We interviewed for symptoms of recurrency of cough, wheeze, breathlessness. We didn't emphasize any one particular symptoms because we don't think there are a very good consensus on what people call cough or rales or wheeze or breathlessness. So we tried to capture all of the symptoms. What we emphasized was the recurrency, believing that recurrency is closer to the essence of asthma. We asked for the child having recurrent days where he was troubled breathing from cough, breathlessness, wheeze, whatever. So that was the interview, half an hour, and 10,000 mothers who had young children at home. The overall frequency reported to us was 1 in 3. So 1 in 3 of every child on average was reportedly having recurrent days suffering from troublesome breathing, to an extent that most of them went to the healthcare system. Almost everyone had been to the family practitioner within the past 6 months. Many had been there several times. Many had been to outpatient clinics. Many had been to emergency rooms, and quite many had been hospitalized. So the level of significance is high. It's not just a cough. It is a cough recurrently suffering that brings the child to healthcare system. 1 in 3 of every child for the past 6 months, across Europe, across the US. What is interesting, besides documenting that this is highly prevalent, which you all knew in advance, what I think is interesting, another perspective that comes from this survey, is the regional variation. We saw a very dramatic regional variation in the use of medication. Overall, inhaled beta-2 agonist was the most commonly used in all regions. But second, it varied quite a lot. In the US, the second most commonly used treatment was antihistamines. In Northern Europe, the secondly mostly used treatment was regular inhaled steroid. In Southern Europe, it was intermittent inhaled steroid. Third, it was intermittent steroid overall. In the US, it was regular steroid. In Northern Europe, it was regular steroid. In Southern Europe, it was regular steroids. So there is some variability where antihistamine is used in US and Southern Europe, not in Northern Europe. Intermittent steroid are used predominantly here in Southern Europe, and oral steroid are used largely in the US. Also, when we looked at the prevalence of symptoms, there was quite surprising differences, with Southern Europe presenting much more symptoms. And I would very much welcome your input trying to interpret why is it that many more mothers report the child suffering from recurrent troublesome lung symptoms in Southern Europe compared to Northern Europe or the US. You see the total prevalence was 40% in Southern Europe compared to 27 to 29 in Northern Europe or the US. Also, the persistence, meaning weekly symptoms, was more prevalent here. Going to the doctor is more prevalent, yet using the term asthma is less commonly. Use of intermittent steroid, as we've seen before, is more commonly used in Southern Europe. So altogether, I think, what does this tell us? That there is this regional variation in diagnostic practices and in treatment practices. Well, to me, it tells me that this is not evidence-based. If we had had a good evidence base, we would probably have a much more uniform use of diagnostic terms, a much more uniform use of treatments. So this is at least one message that comes from this survey. When we try to group the symptoms according to severity, I have here tried to group them according to the GINA severity grouping, with persistent meaning symptoms reported on a weekly basis. And you see that 10 plus 14, 24% in total is actually reporting the child being suffering every week from recurrent troublesome lung symptoms. So just underlining that these symptoms are actually quite significant. What was also interesting was looking at these children, and particularly looking at those who were on inhaled steroids. We took out those who were treated with inhaled steroids according to the mother, and these children reported more symptoms. And again, I would welcome your input. Why is it that mothers who have a child on inhaled steroids more commonly report the child to be symptomatic? Well, probably one argument would be that those who have the most severe symptoms would be the one you choose to give steroids. But then again, assuming the treatment works, you would expect the treatment to reduce the symptoms. And to me, it's difficult to explain why they have more symptoms, except for the fact that this is very clearly a highly heterogeneous disease. This is not one disease. These 32% of children suffering from recurrent similar symptoms do not have the same asthma. Some of them probably have asthma, and many don't, but they present the same clinical picture. And that is our problem in essence. So I think the survey has given some interesting information. It has certainly emphasized that this is highly prevalent, affecting 1 in 3 to a quite severe degree, 1 in 3 of every young child. It has shown us that we do very differently use terminology, we do very differently use treatments. As long as we don't have good terminology, good definition of the diseases, my take on this is that we should probably emphasize treating symptoms rather than getting hung up on academic discussions on when this is proper asthma. Very clearly, these data reflect we have no consensus. We cannot agree on when it is asthma because we use different treatments, different terminology. Given that, I think it's very important for the child that we emphasize disease burden rather than academic discussions on the proper asthma diagnosis. And thirdly, the data I showed you suggests that there is a heterogeneity in this population, and also suggesting that the response to steroid, therefore, is highly heterogeneous. It is not a magic bullet that can treat everyone. Now, if we should try to look through the evidence we have to help us guide the treatment for these preschool children, this is one way to split them into, on your left side, those who have proper asthma. They are probably the atopic child, maybe the one on the video, probably the mother has asthma, probably the child is allergic to milk, probably she has eczema, all in all the typical phenotype of the atopic-driven asthma child. Probably very severe symptoms. This is one classical asthma patient that is certainly one part of the picture, one part of these many young children suffering from similar lung symptoms. And then you have another and very large group of patients to your right, those who have symptoms very similar to the asthmatic child, but driven by viral infections. I'm unable in my clinical practice to separate the two. Those who have proper asthma present with the same symptoms as those who have viral-driven symptoms, but probably these patients are very different in their pathophysiology, in the pathogenesis to the symptoms, and we have to address them separately. I want to use this separation, this attempt of separating different phenotypes, looking into the evidence we have on treatment. And I want to first focus on the easy group of patients, those who have classical asthma. So the atopic, severely asthmatic young child, because this is where we've done by far the most of the studies. We have reported quite many studies in these group of patients, and we've always, until recently, picked the most severe patients to randomize into our different trials. And this is what everybody else has been doing also. So by far the most evidence is gathered from the patients who have severe, persistent asthma. One of the studies we've published is this one. It's showing that steroids are very effective in this population. Again, I remind you, in this study we randomized in the multi-center trial those most severe patients in all the centers. They were randomized into treatment with placebo, or a low dose of steroid, or a higher dose of steroid. And the primary outcome was exacerbations, and we could show a nice and significant dose response, meaning that those on inhaled steroid had fewer exacerbations. That was a very nice study, and it was published, and we emphasized that steroids are very efficient for treating proper asthma in young children. And I still believe that is true. You see a reduction in exacerbation rate by 50%, which is good. But then again, it's also interesting to revisit the data and look at the data one more time and see that, yes, this was very good, but we didn't really solve the problem because half the exacerbations were unchecked. And this is actually very interesting for you to go home and revisit all the papers you've read documenting the effect of steroids and try, instead of focusing on the p-value showing that there is an effect, try to look for all those patients who were not checked. And you will see in each and every paper that even though we show an effect, there are many patients who are unchecked, who have remaining symptoms, remaining exacerbations, remaining loss in lung function, remaining increased bronchial hyperresponsiveness, and whatever outcome, there are always patients unchecked despite a good dose of steroids. So my conclusion is that yes, steroid is a God's gift to asthma treatment, but it is not a magic bullet. There are many patients unchecked despite steroids. Begging two questions. One question is then who is it? Who is responding to the steroid? Who should I give the steroid to? Maybe the young child on the video? Help me predict who is the good responder. And begging the other question, what should we do about those patients who don't respond to a steroid? The first question, how can we predict? We tried to reanalyze the database looking for certain phenotypes that would predict the response, and there was some help. One of them was that young age was certainly a negative predictor, meaning that the very young children under 2 really showed no effect from steroids. The whole effect in the study we published was driven by the older children. So that may be some help in clinical practice, and it's been substantiated in other studies, having very difficult finding effects in the very young infants. There was also a suggestion that the most severe patients are the ones that respond the best to the steroid. And there was an indication that having asthma in family was a predictor, and interestingly and importantly, being atopic does not help you predict response to treatment. Probably a very common misunderstanding, because atopy predicts long-term outcome of asthma. meaning the child is more likely to continue being asthmatic if he has atopy, eczema and whatever. But that is something completely different from predicting response to treatment. So having atopy does not predict your likelihood of responding to a steroid. The other question was, what could we do with those who didn't respond to a steroid? Well, we have one alternative, which is leukotriene receptor antagonist, and we did such a study, looking at very much the same population, those to the left in my spectrum, those more severe, persistent, symptomatic children, were randomized into placebo or leukotriene blocker for 3 months. And one more time, it was exacerbation that was the primary outcome. And you would see exacerbation rate on placebo to your left and exacerbation right to your right on montelukast. And you will see there is a significant reduction in exacerbations if you put this group of severe persistent asthmatics on leukotriene blocker. So we have an alternative treatment, or I should say a complementary treatment. And then again, the same question, it's good, but it is no magic bullet. Leukotriene blockers is by far a magic bullet. It has well-proven, well-documented effect, but as well it is documented that it doesn't work in everyone. Begging the same two questions, who are responding and what should we do about the others? Who are responding, we analyzed, we looked for age, that had no bearings on the effect. Disease severity didn't have any impact on the likelihood of responding. Asthma in the family didn't. And one more time, having atopy is not a predictor whether you are going to respond to leukotriene blocker or not. So that's not very helpful, is it? That leaves you with trial and error in your clinical practice, because we cannot predict, based on clinical phenotypes, whether the child is likely to respond or not. My conclusion on this evidence is that, importantly, it should be emphasized that you cannot use predictors for long-term outcome of asthma, such as atopy, to predict your likelihood of response to any of the treatments we have today. We have no good predictors. Very importantly, I believe steroids is a very efficient treatment for children with asthma, even the young children. It is very efficient, and I believe it's very safe. In the appropriate dose within the label, I don't see a risk of a side effect, and I don't think we should make choices of which treatment to take based on fear of side effects. It is more of a ghost than it is reality. I think what we should focus on is the best possible efficacy, because the safety is taken care of, as I see it. But steroids are effective, but certainly not in everyone. That should be remembered. Likewise, leukotriene blockers have a well-documented effect, but not in everyone. So there is no magic bullet. And since there is no magic bullet, my approach, and that's my personal interpretation of the data, my approach is that I give them both treatments. Any child in my clinical practice receives both treatments to start with, to optimize her chance of obtaining control. And when I've obtained control, I back off one of the treatments. The reason for that is that nobody can help me predict who is going to respond to either of the treatment. The one child on the video may be responding to one or the other, so I give her the optimal chance by combining the two to start off with, and then backing off when we have obtained control. That was the easy part. That was where we have most of the evidence. That was the child with persistent chronic asthma. This is very well substantiated. I believe these conclusions hold. I think it's well documented. I think this is where we have a good case, and these are my conclusions. When we move to the other side of the spectrum, to the right, the viral-driven symptoms, it is much more difficult. We have very, very little evidence published today. We have few studies, small studies, inconclusive studies. And yet this is probably the majority of the patients, so we have to make some choices. Let's try to walk through what we have. And let's start with the most, let's say the most clear-cut viral disease, which is bronchiolitis. This is a child with no history of lung symptoms, who has his first viral infection and reacts with a bronchial obstruction and is typically brought to hospital 3 months of age, and we have no treatments. Steroids doesn't work. There's been numerous studies looking at systemic steroid, intravenous, oral steroid, even inhaled steroids, and they are, at least in meta-analysis, the overall conclusion is that it is a negative. We have no effect from steroids in bronchiolitis. So many of us probably don't use steroids, at least until we are in dire straight, very severe cases. There is no evidence for using steroids. Attilio showed you this slide previously, showing you that there is hope. There is hope because we know that in this bronchiolitis patient there is one pivotal mediator. There are probably many mediators, but one we know, which is the leukotrienes. This is a study looking at patients, young infants, who just had a common cold, infected with RSV infection. To your left, low levels of leukotrienes in the nasal secretion. And to your right, another group of children who also were infected with RSV virus, but reacted with bronchiolitis, lower airway inflammation, and they had very high levels of leukotrienes. So this is suggesting that one of the key mediators in children who, for some reason, are unable to check the RSV infection and react with bronchiolitis, one of the key mediators seems to be leukotrienes. So therefore, it is no rocket science to build a protocol where you study a leukotriene blocker in children admitted with bronchiolitis. And so we did. A number of years ago, we randomized children hospitalized with RSV bronchiolitis into treatment with placebo or a leukotriene blocker. Young infants hospitalized, and when they were sent home from hospital, we gave them either placebo or leukotriene blocker, because we were not focusing on the acute phase. We were focusing on this bronchial hyperreactivity that Bonner explained to you previously, which is one of the main causes, one of many, but one main cause of recurrent cough and wheeze in young children. Not forever. They probably don't grow into asthma, but they have many years of recurrent cough and wheeze looking like asthma. So probably one phenotype that looks like asthma, but it is not asthma. So in this study, we tried to treat them after hospitalization, see if we could reduce this recurrent cough and wheeze, and we could. In the pilot study, you see the outcome is given to you here as the number of patients who becomes asymptomatic over time in the 4 weeks after they're sent home from hospital. The gray line shows you those who are on placebo, and you see that 4% at the end, 4% have become asymptomatic. The 96% are still coughing and wheezing after this hospitalization. But the red line, those who were given montelukast, 24% are asymptomatic after 4 weeks. Again, shows an effect, very interesting, but it is not a magic bullet. Still many patients are suffering. But it is interesting because it is the first time, if this holds true, it is the first time that you may have a treatment helping symptoms induced by virus. We have no other treatment for viral symptoms. So if this holds true, it is interesting. And I emphasize this if, because I don't want you to take this evidence and go home and use it in your clinical practice. I don't think this is sufficient evidence. I only show it to you because I think it's relevant and interesting, food for thoughts, but it is insufficient as evidence for treatment of your patients. Fortunately, Merck is now repeating a similar study, copying this one, but in a much larger scale. We did this in Denmark, small study of 116 infants. They are currently repeating a study of 1,000 infants in a similar design and hoping to complete randomization or inclusion of patients early next year, hopefully seeing the final data by the end of next year. And if this confirms this study, this is good news, because this will be the first time ever that you will be able to have some effect on viral-driven symptoms. So this is sort of two extremes of the spectrum if we try to understand this heterogeneous cough and wheeze in young children, the classical asthma, the viral-driven bronchiolitis, and then in between we have those who have episodic asthma or intermittent asthma or viral-driven wheeze or whatever you want to call it. Those who are generally asymptomatic between viral infections, typically asymptomatic during the summer, but when they have the first September viral infection, they have an asthma attack being brought to hospital. Very difficult group to treat, no good evidence. It's probably early asthma, it's probably viral-driven. How should we treat them? Steroids are probably not effective. However, I want to show you a study that we have very, very recently completed, and actually this is the first time it will be shown in public. It's been submitted for review, and otherwise it hasn't been published. I have no abstracts, but I'm going to show it to you because I think it's interesting. I hope it will have some interest to you also. What we did here was we tried to treat these episodes, children who had episodes of cough, wheeze, breathlessness. And the hypothesis was that if we treated with steroids these patients who have early episodes of asthma-like symptoms, we might have a long-term effect. This is early intervention taken to its extreme. We tried to do very early intervention. So in this study, we tried to treat infants every time they had an episode with inhaled steroids. And the aim was to look at long-term outcome. And also, the secondary hypothesis was to look at short-term outcome, meaning, does it have an effect if we give inhaled steroid during episodic wheeze, during episodic asthma? So this is the study concept. This is the two hypotheses. If we treat episodic asthma from early on in infancy, will we see a long-term benefit, reducing the rate of asthma? And secondly, will we see an acute effect from the inhaled steroid on the acute episode? That was the study we completed. And it is a pretty large study. It's a 3-year study. And it included patients from our ongoing birth cohort study, where we have 411 infants included during pregnancy. All the mothers had asthma, and we included their offspring into the cohort. And from this birth cohort, we enrolled children into the randomized controlled trial at 1 month of age, a double-blind, randomized, placebo-controlled trial for 3 years, where every time they had an episode, we gave them 400 micrograms of inhaled steroids for 2 weeks, or matching placebo. And it was tightly controlled, meaning that every mother had a diary card to fill in, and an episode was predefined as 3 consecutive days of troublesome cough, wheeze, breathlessness. If she had such 3 days, she was invited to the clinic, and we started 2 weeks of treatment with steroid or placebo, looking for short-term effect and long-term effects. 294 children participated because they qualified having an episode during the first 3 years of life. Mind you, we followed them from first month with daily diary cards, and we picked up every episode, and we tried to treat if there was one. 294, meaning some 75%, did have an episode and had at least one treatment. In total, we treated 1,084 of such episodic asthma episodes, wheezy episodes, during this 3-year double-blind randomized trial. By the age of 3, we saw asthma prevalence of 24% in those on steroids, and we saw an asthma prevalence in those on placebo in 21%. So the trend did not favor use of steroids for preventing asthma development. There was no statistically significant difference, but 24% on steroid, 21% on placebo. Symptom-free days over the 3-year observation period was 83% in those who were given steroids for their episodes and 82% in those who were given placebo. Need for add-on, meaning if we had an episode where we gave the trial medication and still the child needed more medication, we gave him add-on extra 400 micrograms. That happened on 59 occasions in those on active treatment and 37 those on placebo, with no statistical difference. But again, the trend seems to favor placebo. So it's very consistent in all the outcomes that we have no long-term effect from early intervention with steroids in this young age group, which has been probably one of the drivers of the proliferating use of inhaled steroids early in life, expecting that early intervention may have a long-term effect. Short-term, there is no effect either. Symptom-free days during the 2-week treatment periods was 47% on budesonide, 45% on placebo. Rescue-free days, 71% on budesonide and 72% on placebo. Not even a trend suggesting an effect, even a short-term effect of inhaled steroid. So the conclusion from this study, 3-year randomized controlled trial in 411 infants, is that there is no short-term or long-term benefits from intermittent steroid in episodic wheeze, even in this high-risk population where all the mothers have asthma. Study is under review and hasn't been published. The data are very consistent, and I think it should reduce the use of intermittent steroid in this age group. Then you may say, well, this was probably not very severe asthma attacks. They were probably only mild because they weren't hospitalized. And then I can refer you to another study which was published in The Lancet 2 years ago, where they looked at children who were admitted with episodic asthma in relation to a common cold. 217 young children who had been admitted with acute wheeze in close relation to a common cold and given either placebo or prednisolone, 20 milligram for 5 days, and the authors found absolutely no effect from the steroids. So whether you look at the mild intermittent episodic asthma or you look at the severe episodes bringing the child to hospital, steroids have no effects. That's very negative, isn't it? Then what do? Well, we have not the solution that we have some evidence for some effect using leukotriene blockers in this population. We recently published this study which was looking at treatment with leukotriene blocker in those children with episodic asthma. It was a double-blind, placebo-controlled randomized trial of 1-year duration comparing leukotriene blocker with placebo, 522 patients, 2 to 5 years of age, who had a history of episodic asthma. No symptoms over summer, no symptoms outside the common cold, but when they had a common cold, this was their symptoms typically. So this diagram shows you the typical symptom pattern of a child with episodic asthma. What I'm showing you here is centered around the first day of the first episode. That's 0 in the middle on the x-axis. And the symptom from the diary cards 1 month before and 1 month after, you see that they have literally no symptoms until they have this first attack that shoots up within a day or two, lasting 8 to 14 days, and then they're back to having no symptoms. So this is the patient population we studied. You may call it episodic asthma, intermittent asthma, or viral-driven wheeze, or whatever. Those children with clear-cut episodes and no symptoms outside common cold. Active treatment with leukotriene blocker gave us a reduction in the rate of episode by 1/3, which is good considering we have no alternatives, but which is certainly not a magic bullet either. This is not a wonder treatment. 2/3 of the population was unchecked, or 2/3 of the episodes were unchecked. So the message, the take-home message is leukotriene blockers do have an effect, but it is not a magic bullet, and we would very much like to know who will be responding. So we repeated what you've seen a couple of times now, an analysis trying to look for predictors. Who will respond if they have episodic asthma? What kind of patient profile can we help you with? Is it depending on demographics such as gender, age, or race? Nope. No prediction. How about disease severity, which we monitored by use of beta-2 agonists? Didn't help us predict who would respond. And for the third time, I show you a study showing that atopy, however well it may predict asthma long-term outcome, it does not help you predict response to this treatment. Now you may say, this 1/3 reduction I just showed you, is it really worth it? The study we did, we gave them for 1 year a treatment every day, reducing exacerbation rate by 1/3, probably going from 5 episodes a year to 2 or 3 episodes a year. Is it worth it? And I would probably say it is not worth it. I don't think many of us would put a child on daily treatment all year round to reduce from 5 to 3 episodes. But you should see this as a proof of concept. This is not guiding your management, but it is proving the concept that blocking leukotrienes can reduce to some extent the episodes. And then it's up to you in a society like this to discuss how should you bring it from proof of concept into management. Or you may look to the Australians, who were a lot smarter than we were. They saw the concept worked, and then they took it into a more manageable approach, because they gave it to the mothers to have at home and told them to start the treatment on the first day of the common cold, or for the very good mothers to give it 2 days before the common cold and continue for 1 or 2 weeks. So intermittent treatment for intermittent episodes. They did a similar study to ours, only including somewhat older children up to 14 years of age, but again with intermittent asthma. Gave them 2 weeks of treatment, 1 to 2 weeks of treatment starting from the common cold during a 1-year study period, enrolling 200 children, having altogether nearly 700 episodes. And they saw that they reduced exacerbations by 1/3, very similar to our outcome. Their outcome they call healthcare utilization, meaning having to go to a doctor or a hospital or emergency room to take care of this exacerbation, and that was reduced by 1/3. Very similar to the study I showed you before. When they analyzed specifically the emergency attendance, it was reduced by half. And when they counted number of days the children had to stay home from daycare or stay home from school, it was reduced from 550 days to 350 days, which is clinically a very meaningful outcome. So they have taken the proof of concept into a more manageable approach, blocking leukotrienes with a leukotriene blocker during viral episodes only, not every day. And this, I think, is a very interesting approach. So let me finish by summarizing the take-home messages I've tried to present to you. I've shown you a survey, a very large survey from Europe and US, attesting to what we all know. This is very common. The recurrency of wheeze, cough, breathlessness, whatever you want to call it, affects 1 in 3 of every young child, and is the largest chronic disease in children. As long as we have this inconsistency in terminology, diagnostic criteria, and use of treatment, I think it's very important for all of us to emphasize the need to focus on the symptoms of the child, not get hung up on specific diagnostic criteria for asthma. I think it's important to emphasize that steroid is a wonderful treatment to asthma. I believe it's safe when used in appropriate doses, but there is a heterogeneity. It is no magic bullet. We need alternative or complementary treatments. I showed you data that episodic wheeze respond to leukotriene blockers, but they do not respond to steroids. Episodic asthma cannot be treated with intermittent steroid. Regrettably, I were unable to help you with a clinical profile of which patients should have what treatment. It is very much up to either a trial and error, or maybe you would follow my suggestion that until somebody can help us predict who will respond, we have to give them both, to give them the best possible chance to obtain control, and then we can always back off either of those 2 treatments. Many don't like this conclusion of combining treatments from the beginning. Many would prefer to take one treatment first, and if you belong to those who want to have one treatment first, financial arguments are weighing heavily in here. So if you do want to choose one treatment first, my take on the evidence is that steroids, the evidence we have suggests that they are more likely to be the most efficient treatment in the older population. So the older, younger child, if you like, whereas the young infants have shown very little response to steroids. And you're more likely to be successful using steroids in the most severe cases and not the less severe cases. And definitely, you should not use a steroid for viral-driven intermittent symptoms because we have heavy evidence suggesting that it does not work short-term or long-term. Then where can you put in leukotriene blocker? Well, the evidence suggests that it is effective for asthma, which is driven by the common cold. And then you can choose to give it on a regular scale every day, maybe during viral season, or you can take the Australian approach, giving it intermittently. So altogether, I think we have a long way to go before we can help this 1/3 of the population, but also I see new interesting data that may help us in the future. Thank you very much.
Thank you, Hans, for your complete and really up-to-date talk. So please stay in the podium. Professor Bisgaard è andato un po' oltre quelli che sono i tempi a lui consentiti, ma abbiamo circa una decina di minuti per la discussione. Prima di fare le domande vorrei cedere un attimo la parola alla professoressa Balli perché ha una breve comunicazione da fare.
Intanto che vi preparate per le domande, che sono sicuramente importanti e ci sono, volevo fare solo un flash sulla situazione dell'asma in Emilia-Romagna, perché proprio da pochi mesi abbiamo ricevuto dalla Regione quella che è la relazione dei pediatri di famiglia su questa patologia cronica, e l'asma è la patologia cronica più frequente rispetto a tutte le altre, seguita poi dall'obesità, della quale si parla tanto non solo in ambiente scientifico ma anche sui giornali. L'asma è la più frequente, ma quello che importa di più è che il 10% dei bambini asmatici, in una regione in cui credo che la sanità abbia raggiunto dei livelli buoni, penso di poter dire, bene il 10% non hanno un progetto assistenziale, un progetto terapeutico e quindi vengono seguiti solo saltuariamente. Quindi abbiamo sempre più bisogno di fare quello che stiamo facendo da questa mattina, conoscere di più e avere più.
Bene, allora passiamo alle domande. Vedo che ci sono anche dei pediatri in sala, quindi l'opportunità di avere il professor Bisgaard è molto ghiotta. La professoressa Setta, che è una pediatra studente, mi sembra di capire, no?
Sto imparando. Thank you for your talk, was very interesting. So what could be the reason of the potential mechanism through which steroids do not work in episodic asthma and leukotriene blockers do work?
That is clearly the $100 question. Why is it? Why is it this different profile of their efficacy? Why is it steroids have no effect in viral-driven symptoms, and why do leukotrienes have an effect? Probably I cannot answer it, but it's very interesting. What we know is, though, that leukotriene pathway is unchecked by steroids. We know that this part of, steroids take very well control of a large part of the asthma inflammation, but leaves the leukotrienes unchecked. And apparently viral-driven inflammation particularly drives the leukotrienes and emphasizes the leukotriene-driven inflammation. We have in vitro data on that, and I think Stephen is ready to answer that point. And probably that's the explanation. It's different part of the inflammation they check.
Thank you, Hans. It always surprises me that we know so little about exacerbations, when in fact, from the patient's point of view, this is the most important part of asthma, and indeed COPD, I suspect. And even in little children, or children at school, it's exacerbation really that causes them the problem. I mean, they can cope with their exercise asthma if they're given proper advice. And it really is surprising that the pharmaceutical industry hasn't targeted the exacerbation as a molecular target to try and develop some new approaches to therapy. I think, as you point out, it's been assumed, and I think wrongly so, that asthma broadly across the spectrum is a Th2-mediated disease involving the allergic sort of pathways. And I think you've illustrated so beautifully in your talk, and Attilo also illustrated it in his, that there are separate components to asthma that clearly have little to do with the Th2 type inflammation. In Attilo's case, maybe structural changes, maybe poorly developed airways, whatever. In your case, beautifully illustrated, is a separate pathogenetic mechanism. And we know that viruses, whether it's human common cold viruses or whether it's influenza virus or whatever the virus is, gains access to the airways through the epithelium. And that's the target for where the therapeutic should be directed, presumably. And we and now another group in the United States have shown that increased susceptibility to virus infections, including influenza virus, is a result of impaired interferon beta production. So here we have a completely separate molecular pathway involved, which is all about innate immunity and the epithelium, which has nothing to do whatsoever with mast cells and Th2 T cells and allergens or whatever. And I think really what we should be looking for, Hans, is something now that can induce the secretion of interferon beta and interferon lambda, which is the other interferon involved in this, which will then increase the innate protection of the airway against recurrent different virus infections.
It is interesting that despite we obviously have good treatment effects from steroids on the truly asthmatic child and also the very young child, at least in our country, in the Nordic countries, we see very little reduction in hospital admission rates on the whole. Hospital admission rates for school children has dropped dramatically with the introduction of steroids, but it has not really changed after we introduced steroids. So even, and that's just underlining what Stephen said, that even though we have control of day-to-day symptoms often, it seems as if exacerbations is a different pathophysiology because we don't obtain the same good control of exacerbations. If you look at day-to-day symptoms, we're much better controlling them with steroids, for example, but exacerbation seems to escape via some other route, and whatever route that may be. I may even add that I should probably have shown a extra slide on this trial we did, because what we did was we actually identified the virus during every exacerbation, and approximately 60% were having a virus we could identify, or Seth Johnston could identify, and the effect or lack of effect was totally independent of virus being present. So it's probably not only virus, it's probably some other pathophysiology that virus triggers, but also other factors trigger. So we're very much at loss. So your question is very important, but we can't answer it.
Thank you, Hans, for your presentation. You showed us a slide with increased leukotrienes in airway secretion after RSV bronchiolitis, but after age 1, rhinovirus are much more frequent. Do you know some data demonstrating if after rhinovirus infection there is an increase in leukotrienes in the airways?
Now that's a good point, Eugenio. This and a few other studies have documented very well that RSV releases leukotrienes, and then, as you say, RSV is not a main driver in older children, in 2- to 3-year-old children, but the rhinovirus is probably, or is definitely much more common. I have seen no data in vivo showing a similar increase in leukotriene release, but I've seen in vitro data, I believe from your lab, Stephen, showing that rhinovirus can upregulate the lipoxygenase pathway also. So I think my interpretation from in vitro and some in vivo that it is a common pathway to viruses. I don't think this is specific to RSV. To me, RSV is just representing the virus. We have most data there because we could analyze it for many years, but I think it's just a common pathway. And I think your in vitro data would support that, yeah. Stephen is nodding.
Is the other cell that comes out very prominently here, the neutrophil. And we'll get into a debate about that maybe at a different time, but the fact that the inflammation may be neutrophil-driven, very strongly dependent upon neutrophil-like products, including tumor necrosis factor alpha, suggests that it's a more tissue-damaging type inflammatory reaction. Whereas, of course, the allergic pathways, there are obvious routes whereby steroids could suppress them. But if you're actually killing cells cytotoxically, as happens in virus-induced injury to the airways, then it's hard to see why a steroid would necessarily have a beneficial effect. And I think the same might be true, Leo, in COPD, though I have less information on that.
If I may enter in the discussion, and then I come back to a couple of questions for your presentation. I'm glad you mentioned, Steve, the exacerbation of COPD. We know very little, and but some very relevant clinical message that is coming from a recent study we completed with Alberto and Seb Johnson is, one, purulence doesn't mean neutrophils. Purulence may also be eosinophils. So just to see a green, or which is a simple, maybe you knew about it, but many people don't believe that. Right. It's actually, now we have the numbers. Second, that when you have a viral infection associated with an exacerbation, we don't know whether it's causal or not, but associated either by itself or combined with bacteria, you have eosinophilia. So, and the third problem that we have in adults, that I don't know, I suspect, I hope you don't have in children, is that we call exacerbation an increase of respiratory symptoms on top of the symptoms that they have. Now, but the symptoms are dyspnea mainly, and cough and sputum. For cough and sputum, it's reasonable to think that they're due only to the lung or to the airways. For dyspnea, we have to cope with cardiac failure, which is sometimes very relevant, thromboembolism, pneumonia, that are by classification called complications, but if you don't look for them, you don't find them. You know, if you don't look for the dimer, if you don't look for the if you don't measure echo, the pressure and all that kind. So we have also a differential diagnosis problem. So one of the questions is, I can't think about, I don't know experience in kids, but do you have this problem? Do you have a problem of differential diagnosis? And the second question, so I put all together, is a very practical one once again. I enjoyed your critical view of the, and I share all of your opinion on your critical view of the, and because of this, let's say, conflicting results of anti-inflammatory approach in children, is any room for treatment of children with LABA alone? Because in adults is a no-no. You know, they are less efficient as steroids, and also they may be dangerous. But in asthmatic children, is any room for just the long-acting beta-2 agonist, or even, crazy to think about, for the long-acting anticholinergics? Or is any data available?
Good questions, meaning difficult questions. For the LABA, I would say there's no room for monotherapy with LABA. I don't see a place for that. I think we all were taught 10 years ago not to give simple bronchodilators, but to check the underlying inflammation. So today, no, I wouldn't say that. I don't think there's a role. Geotrope is fascinating, and we've been trying to do such studies because it's a very obvious study to do, look for an effect on secretion, which is large part of the symptoms in young children particularly. There are no data as such today, so we cannot recommend it or know how they would react, but it's very interesting. Differential diagnosis, there are plenty. There are really plenty of them. I suppose most of us are confused with separating the asthma from the infectious child, but besides that, there are more severe differential diagnoses, and Telio listed them, I believe, many of them: tracheomalacia, cystic fibrosis, cilia, dyskinesia, foreign body, etc., etc., etc. So there are very many, actually, there are very many, absolutely. Very, very important. No, I wouldn't say for exacerbations as such, unless it's a foreign body. Okay. Telio, would you have a... No, I don't.
Even though we have less problem than the others do have.
It's not for the excessive.
Il professor Fave mi dice che abbiamo ancora qualche minuto prima di chiudere, allora se non ci sono altre domande faccio io una domanda al professor Bisgaard. So in one of the first slides you showed the use of different anti-asthmatic drugs in different countries, and I realized that there is an increased prevalence of the use of intermittent inhaled steroids in the South Europe. This is despite the lower diagnosis of asthma in this country. Do you have an explanation for this? And do you think that probably this can also be due to some pharmaceutical pressure?
Oh, I'm sure there is a huge pharmaceutical pressure, and that is driving our treatment tradition much more than the evidence is. I think there are many examples for that. The current dramatic increase in combination product use in pediatrics is just one recent example of the tremendous pressure from industry. I don't know if I can blame them for this highly differentiated treatment approach. I mean, it's not just Southern Europe, it's between US and Northern Europe, it's all over the place. I mean, we have no common treatments, and I don't think really I could speculate on why certain treatments have rooted in US, such as antihistamine, but not in Northern Europe. I really have no explanations. I'm just stunned by the differences.
Thank you very much. So, allora siamo al termine. Io credo che così questo percorso che il professor Fabbri ha costruito in questa sessione sia stato veramente ottimale, perché abbiamo sentito un po' quella che è la parte clinica, i diversi fenotipi, ci siamo addentrati poi nella diagnosi e poi infine il professor Bisgaard ci ha dato, credo, non ci ha dettato delle regole assolute, ma credo che ci ha dato dei punti di riferimento, perché poi ognuno con la propria esperienza, in base naturalmente a dei dati importanti della letteratura, può scegliere in fase di trattamento. Ringrazio personalmente i relatori per il loro contributo e naturalmente il mio co-chairman, il professor Fabri.